and silence your devices. So a couple of quick housekeeping notes before we begin. This Grand Rounds will be recorded and will be made available after today's session. For those that are in the room, there are microphones at either side of the room for the Q&A portion of the session. If you are sitting at a desk, there are microphones as well on your desk, and you can use those also. Please note that continuing education credits are not being offered for this session, but we hope to do so for future Grand Rounds. Okay, so let's get ready for a great session.
Attention on deck, please stand. Please stand.
I guess I'm on the bit of it. Yeah, she's a tipster.
Oh, wait. As you can tell, I'm not very good at protocol, but I'm absolutely delighted to have everybody here for this big event. I welcome you to the return of the CDC Public Health Grand Rounds. It's an absolute pleasure to join you as we relaunch this important forum. It's been apparently 7 years since we've had the last Grand Rounds, and this is not the last Grand Rounds, even as for my tenure here. And I'm just want to thank Althea for just being a leader in organizing this. The idea is scientific exchange, thoughtful discussion on critical topics that shape public health and practice. And you know, it's a new chapter for the Grand Rounds. It's one that built on a strong tradition. When I was a few years back in the before times, I actually got to attend one at the CDC. And so it's really an honor to be able to introduce this. The CDC Public Health Grand Round stands as a cornerstone in the agency's scientific and educational culture. It brings together experts and practitioners, researchers and leaders to examine emerging issues, explore new evidence, challenge assumptions, and learn from one another's perspectives and experiences. Today's session marks more than a return of a value tradition. It reflects a renewed commitment to the principles that drive scientific progress: excellence, collaboration, transparency, intellectual curiosity, and the willingness to engage in thoughtful debate on complex issues that influence the future of public health. Our topic today, methodologies for measuring vaccine effectiveness, offers an ideal opportunity to explore different scientific approaches, examine their respective strengths and limitations, identify gaps in knowledge, and consider opportunities to advance the science. Vaccine effectiveness studies help us understand how vaccines perform in real-world settings and how they protect people from outcomes such as illness, hospitalization, and death. This topic is the perfect kickoff for the return of Grand Rounds because it underscores the importance of open and transparent scientific discourse. Advancing public health requires us to ask difficult questions. We have to evaluate competing perspectives. We have to examine what we know and what we do not know, generate timely evidence, and translate scientific findings into action. Strong science thrives when experts engage in meaningful, respectful debate, challenge ideas, and follow the evidence wherever it leads. So, the relaunch of the Grand Rounds Public Health Grand Rounds series reaffirms the CDC's core values: thoughtful discussion, scientific discussion, and the use of science in the pursuit of good public health. Public health challenges rarely fit neatly into a single field of expertise. Addressing them requires collaboration, curiosity, critical thinking, and commitment to learning from diverse viewpoints. As we look ahead, I hope this series will serve as a catalyst for new ideas, stronger partnerships, and deeper understanding across many disciplines that contribute to public health. Your participation, expertise, and perspective will ensure these discussions remain relevant, impactful, and connected to the work we do. And let me just finish on a very practical note. We're going to have lots of these Grand Rounds, and what I'm asking you all to do in the context of these Grand Rounds is to bring us topics that you think we should talk about for future Grand Rounds. They shouldn't just come from the OD. It should come from the CDC. The topics you want to see addressed will be reflected here in the future. I'm grateful to all of you for being here, and grateful for the participants for this inaugural Grand Rounds to be here for such an important event. Thank you so much.
Good afternoon, everyone. Thank you, Dr. Bhattacharya. I'm going to take a moment to explain how Grand Rounds will run today. It's a little different than the format you saw before if you were at Grand Rounds of previous years. This is a discussion-driven session, not a series of standalone lectures. You'll first hear 3 short expert presentations, each building on the one before, followed by a brief reaction from our discussant. We'll then move into the heart of the session, a moderated cross-panel discussion where panelists will compare their perspectives, maybe surface points of disagreement or agreement, and get practical about what the evidence means for real-world public health decision-making. We'll close with a live Q&A, so you in the audience will have an opportunity to ask questions, so please hold your questions to the end. And I'll also give you our learning objectives for today. So our objectives and goals for today is that by the end of this Grand Rounds, you'll be able to explain why CDC's routine vaccine effectiveness monitoring is essential for public health decision-making. You'll be able to compare vaccine effectiveness measurement today with near future capabilities. You'll be able to describe the infrastructure, meaning coverage, linkage, timeliness, governance needed to scale vaccine effectiveness monitoring across jurisdictions. You'll be able to explain when the test negative design may not be the best fit for vaccine effectiveness monitoring and what the reasons are behind that. You'll be able to weigh the strengths and limitations of observational cohort studies and randomized evidence for assessing vaccine effectiveness. Before we begin, I'm going to introduce our esteemed speakers for today. First, we will have Dr. Carrie Reed. Carrie is an epidemiologist and branch chief for the Epidemiology and Prevention branch of the Influenza Division at CDC. She oversees public health surveillance activities related to influenza in the United States. She has over 18 years of experience at CDC focused on the application of epidemiologic studies and mathematical modeling and public health response to seasonal and pandemic influenza. Next, we have Dr. Emily Martin. Emily Martin is a professor of epidemiology at the University of Michigan School of Public Health, where she directs the Center for Respiratory Virus Research and Response. She's a core investigator in CDC's U.S. Influenza Vaccine Effectiveness Network and Ivy Network, with research spanning influenza, SARS-CoV-2, and RSV. She'll give us an overview of vaccine effectiveness monitoring and our methods toolbox. Then we will have Dr. Martin Kulldorff. Dr. Kulldorff is a biostatistician and epidemiologist serving as the Chief Science Officer and Data Officer at the HHS Office of the Assistant Secretary for Planning and Evaluation, and formerly professor at Harvard Medical School. His statistical methods for vaccine safety, surveillance, and outbreak detection are used worldwide. He'll examine the challenges and limitations of test negative design. And finally, we will have Dr. Natalie Dean, who is an associate professor of biostatistics and bioinformatics at Emory University's Rollins School of Public Health and an expert on vaccine evaluation and clinical trial design during outbreaks. She'll serve as our discussant. So to begin, we will have an overview in public health uses of vaccine effectiveness by Dr. Carrie Reed, and I will turn it over to Carrie.
Thank you. It's good to be here this afternoon. So I'm going to use this time to set the stage for what you're going to hear more of in the presentations and discussion that we'll hear this afternoon. So just to start out, as was mentioned, we're talking about vaccine effectiveness today. And many of you are familiar to me, and I know you know a lot about this, but to set the stage, when we're talking about vaccine effectiveness and measuring it in epidemiologic studies, what we're measuring is a population level estimate. If a vaccine study measures a vaccine effectiveness of 50%, for example, it doesn't mean that the vaccine only works 50% of the time. What it does mean is that people who are vaccinated this season for annual vaccines like influenza, for example, had an estimated 50% lower likelihood of having the outcome, for example, an influenza medical visit, that's the study we're doing, compared to people who had not been vaccinated this season. So we're really talking about the additional gains from, additional benefit from vaccination this season compared to whatever background immunity, prior infection, prior vaccination in the population going into the season. And so when we think about the various studies and the various numbers we see today, for diseases like influenza or COVID-19 that are very prevalent in the population during their respective seasons, an effectiveness of 50% or even a third can translate to very large numbers of illnesses and outcomes prevented. All right, challenging the situation even more as we get into the discussion here, we know that VE can vary by a number of factors. It can vary from season to season based on the virus that is circulating that year and how antigenically similar it is to the virus represented in the vaccine for that season. It can vary by outcome that we're measuring. And so this has importance for both designing the study, choosing the study design, as well as communicating the results of the study. It can also vary by population. Factors like age, prior health, prior infection, prior vaccination, and time since you were vaccinated. And so all of these things are things that we think about. And when I talk about some of the public health uses, why we need to be thinking about these issues, accounting for them in our studies, and being able to address some of these variations and understand them. There are some study designs broadly in these categories. You'll hear more from other speakers about the details of those, so I'm not going to go into much detail here other than to just set the stage. Again, we have in the realm of epidemiologic studies, these kind of three big buckets of study designs that we're talking about, and you'll hear over the next hour and a half. We have our randomized trials. These are experimental studies where individual participants are randomized to the exposure under study, whether that's a placebo versus a vaccine or one type of vaccine versus another type of vaccine. And we typically consider that these measure vaccine efficacy, so the performance of the vaccine under ideal conditions in a controlled population. More often, what we have post-licensure are observational studies, where rather than randomizing people to a specific exposure, we are observing what happens in the real world. Who gets vaccinated, who doesn't, who gets the outcome that we are studying, who doesn't. And this measures vaccine effectiveness. So this is under real-world conditions, the things that people encounter or choose in their day-to-day life, and what happens to them. And these are more challenging because people make choices. People who get vaccinated are often different in many ways than people who don't. We have to account for those differences in the design, in the analysis, and in the interpretation of these studies. And I'm going to introduce just briefly a test negative design for those of you who may be less familiar with the design. Again, you'll hear more specifics. This is a particular type of a case control study that was initially developed by colleagues in Canada and reported out in the early 2000s. The start of the study is a symptomatic medical encounter. So everybody in the study has an illness encounter, and our cases are the cases that test positive for the disease we're interested in. This was originally developed for influenza, so influenza positive, but it's been extended to use for other pathogens as well. And the controls are similarly people who sought care, but were negative for the disease that we're interested in. And you'll hear a lot more discussion about this. And one of the primary uses of this was to minimize differences due to health-seeking behavior. So your controls should be representing the population that the cases came from. And so other people that would seek care for a respiratory illness represent the population that gave rise to the cases. And as we have seen over many years now, we have certain periods of time where we have the benefit of multiple different studies, of different study designs. And we can use these and look at these and synthesize these and think about how they give us reassurance about different study designs used to measure similar outcomes in similar situations. This is an example from early in the pandemic, the COVID-19 pandemic, where you can see there are a couple of randomized control trials, 2 TND studies and a prospective cohort, all resulting in similar estimates of the vaccine effectiveness. Likewise, a few years later, we have a population now that has largely had experience with either having COVID before or being vaccinated before. And again, likewise, across a number of different study designs, the test negative design, some cohort studies, some TTE, which is target trial emulation. It's a newer way of thinking about how to analyze these data, more like a clinical trial. And again, similar results. And so when we see that we are getting similar results from different types of study designs, that can give us confidence as we are making conclusions and thinking about public health actions. All right, so I'm going to just spend the last 3 or so minutes that I have talking about the public health uses of VE estimates. In the influenza division, we obviously do this every single year to monitor and communicate the annual updated influenza vaccination. But also there are other uses that I'm going to talk about briefly and give some examples to keep in mind as we're listening to the rest of our panelists and the discussion later. So as I mentioned, timely monitoring and communication of updated annual vaccinations. We have a new vaccine that's produced and distributed every season. How is the vaccine performing? Are there any things that we see that we should be concerned about? This is an example from the 2014-15 season, although it could have been similar this season, where we saw predominant circulation of an H3N2 virus that was drifted and less similar to what was in the vaccine. So being able to get out messages early on in the season with early observations and transparency about what we're seeing is really important. This is a different example of a study design that was done during the 2022-23 season. This was a prospective cohort study that was set up during the pandemic for COVID-19, but was still in operation in the 2022-2023 influenza season when we saw the return of more typical influenza activity after the pandemic. And in this graph, this is a incidence of the influenza virus infection in these cohorts based on whether they were vaccinated in the blue line or unvaccinated in the yellow line. And again, we're able to calculate in this type of study design a VE against infection, not just illness, not just medically attended illness. But when we do analyze that to look at VE against symptomatic illness, we see similar results to what we saw in our routine VE monitoring network. And this is a very intensive study design, very expensive, many millions of dollars, that was able to be done during the pandemic. It was part of our pandemic plans, but is not routinely available for seasonal VE. That's not the only way to do cohorts. There are less resource-intensive ways to do cohorts, such as using existing records and existing data from cohorts like older adults across the US who are enrolled in Medicare. And these have been utilized for as retrospective cohorts recently for VE estimates against COVID-19 and RSV. These are large representative studies that do allow us to answer questions about the population included and stratify on different things that we may be interested in because of the size of the data. We, particularly in influenza, this is a really important one for annual strain selection. And globally, that occurs in February for influenza. And so having really early looks at what we are seeing early on through our test negative designs can inform strain selection. And I'm out of time, so I'm gonna move through this, but this is just a quick example highlighting why those early estimates from our test negative design, where we can look specifically at type and subtype and genetic subclade because we're getting specimens, getting them into sequencing, really see that we can see variation based on the virus that is circulating, and seeing that really big difference between these two subclades of H3N2 in terms of vaccine effectiveness. And having that data very quickly in the season can be helpful for communication and strain selection. Briefly, this kind of information goes into recommendations. The example here was, are there specific types of flu vaccines that provide better protection in vulnerable groups like older adults? And designing these retrospective cohort studies in CMS data can be a useful way to start to look at that question. But our recommendations are rarely based on one single study, one finding in one population. And so highlighted here is just a systematic review of the literature and meta-analysis that, among other work, went into the discussions with ACIP to provide a preferential recommendation of certain types of vaccines that would provide better protection in this age group. And then finally, understanding, having platforms that allow us to understand not just the measured VE, but also the mechanisms of vaccine protection. Which groups does it work better in? Which groups does it not work as well in? And getting additional specimens, serologic specimens, mucosal specimens, other things that can provide information to the broader scientific community to improve vaccines. And so just in conclusion, I think these are some points that I think you'll hear from others today as well. V is not one study. It's a collection of evidence from different types of studies, different endpoints that support public health actions. And the different needs that we have that I just went through may lend themselves to different designs, depending on the objectives, and when estimates from different studies are available, that can really reassure us that we are using these estimates in a way that can build confidence in those public health actions. So thank you.
So thank you, Dr. Reed. So our next presenter will be Dr. Emily Martin, who will walk us through while we monitor vaccine effectiveness for seasonal respiratory diseases and the toolbox we use for measuring vaccine effectiveness.
Thank you very much, and thank you so much for the opportunity to speak with you today. So to start out, I wanted to give just a word about my experience. I think it's important to know what context people are speaking from when they're speaking. And my experience comes from this. I did graduate training where I worked on data from randomized control trials. After my MPH, I actually worked as a study coordinator. I was a study enroller. So I know what it's like to sit in an emergency room with a parent and their sick child and try to convince them to take a product that they've never heard of before to treat that illness. So when I talk about feasibility, I feel it in my soul, in my gut. And then I've had a series of academic roles since leaving graduate school. So the goal today is that we are talking about what I see as our overall goal of vaccine effectiveness measurement, which is how do we generate a body of evidence that, when taken together, is going to give us information about vaccine performance against the specific pathogens that are circulating right now, not 20 years ago, right now. And this implies that we need to adapt quickly with the virus as it changes. And so I'm sure you've seen this figure on the left. I actually went back and found the original hierarchy of evidence from the 90s. This one of my citations talks about the evolution of this concept. It's fascinating. But this appears to be this is why it's a kind of 1990s color scheme. And it gives this impression of hierarchy, but really that there are all these types of different observations that form a foundation for our kind of rarest and most resource-intensive efforts up at the top. And then, of course, I can't leave out the Rothman Daily Pyramid, which is, however, any thoughtful and well-designed study is the important evidence. This is what we're looking for. In order to get there, I kept thinking about, so this weekend I was massively working very quickly to try to finish house projects before my daughter's graduation party. So there's me building a deck in the backyard. And the accumulation, I realized as I was working on it, I have 3 different saws that I was working on at the same time to build this deck. My dog's in the back, he was not being helpful, but the 3 saws were. And the 3 saws all served a different purpose. And I needed all 3 of them. And so for that context, that's where I'm going to set the stage for our talk, my part of our event today. So again, as I mentioned, here's our goal. To put more detail behind this idea of taking a body of evidence and then taking the different pieces of evidence together to give us timely information, what does that actually look like? That requires synthesis. It requires synthesis of evidence. And so here I wanted to start with kind of the ending first. I wanted to start with some examples of what that synthesis looks like in practice. So first, an example of VE estimates across networks and populations. So these are numbers from the 2024-2025 season, or this is a paper where those numbers are. And what is important about this, it was 4 different methods, 4 different populations and different outcomes, a variety of emergency room, urgent care, hospitalization, ambulatory care outcomes that were all coming to the same conclusion, and also networks that do their jobs in a little bit of different ways between. And you see this consistency in method. But what I really, the second example here is I wanted to talk about what happened in the 2015-2016 season. Here's a article from JAMA from that season. And this is when we look at one design, and in this case, only one platform, but we follow it over time, and we're able to synthesize across time periods. So any sort of bias or informations that might have been, or misinformation or misclassification in the platform, there are methods to account for it, but then also what we're doing is consistent from year to year, and that allows us to identify patterns that emerge from that. So from that, I want to highlight this because this is a year when one of the vaccine products was performing differently from the other vaccine products, and it wasn't the first year that had been identified. So we had seen a few years in a row where we'd seen the same pattern. Taking this initial report saying, hey, we've seen this pattern for a few years, it was followed internationally. Here's a great summary by Richard Peabody in the UK. It was followed by an effort from countries all over the world, all sorts of different networks, to say, were they seeing similar patterns to what we were seeing? And you can see that over here, resulting in a conclusion of that a series of studies that span the hierarchy, that span different types of studies, are required to follow up on this, from laboratory studies to more VE analyses looking at explanatory factors, demonstrating how these all work in concert with each other. It's more than one platform, it's more than one season. It requires information across a range of outcomes and platforms and methods. And when we do this, when we look at this range across different pieces of information, the different tools are often reaching conclusions that coincide with each other. And Carrie mentioned some of those examples. And there's a long history of this in the flu field, but SARS-CoV-2 gave us the opportunity to look at this in our current medical and testing context, and gave us a wealth of randomized data that we could use to be able to interrogate some of these assumptions. So here's a historical example on the left of using randomized trial data to then estimate what a test negative design would give us and coming up with about the same answer. In the middle, we've got a recently published study using data from 5 randomized clinical trials that did the same thing, estimated test negative design estimates, and you can see consistency in the randomized control trial answer and test negative using the same data. On the right, we have an effort to use randomized trial data to validate the negative control outcome strategy, which I won't get into in my 10 minutes, but is a strategy that can be used in observational data to increase and understand the internal validity. However, so we see evidence here of information coinciding, but what happens when our information does not coincide? What happens when results from different platforms don't line up? And that is when we need to recognize the various strengths of different tools in different situations. So I'm going to talk about a few of those strengths here. First, the randomized controlled trial. Like, it's important to notice first, with the flu vaccine, this, to my knowledge, is the last season there was a randomized placebo-controlled trial of flu vaccine in the United States. It was in the 2007-2008 year, and it was possible because there was not a recommendation at the time for vaccination in this age group. Because flu vaccine was already seen to be beneficial for older adults and those with high-risk conditions. So if you see, though, you may hear about external validity in randomized controlled trials. You can see that shown here. Look at the mean age, 23, of all of these groups. A second issue with randomized trials is that, and we'll see this again with cohort studies, is their size. So with almost 2,000 people followed here, there are only 100 influenza infections. So when we talk about external validity, it also is important to note the number of infections we're getting here. We're not going to get a landscape of strains like we do with other designs. So let's talk about observational trials. Move from studying how the vaccine should work in a tightly controlled ideal situation to how it actually works in the real world, where humans with complicated lives are choosing whether or not to get the vaccine and whether or not to go to the doctor when they're sick. So for the influenza vaccine, there has been decades, there has been decades of history of cohort studies that prospectively follow people and look at vaccine and infection. Here, I'm highlighting various CDC efforts that used cohorts for outcomes that are particularly well matched to the strengths of the cohort design. So frequent illnesses, mild to moderate illnesses, and even asymptomatic detection. And keep in mind that asymptomatic detection can really only be directly measured in a cohort design. And here's some examples of recent studies that have been able to capitalize on those strengths. But as we do these cohorts, we've had lessons learned. It's important to highlight both the decades of work in space, but what we've learned from those decades of work. And that includes the first, which is a methodologic concern, and that's healthy vaccinee bias. So when time periods and outcome definitions are imprecise, and the underlying health status is not appropriately accounted for, results can be impacted by patterns of who chooses to get vaccinated and whether that vaccination is in itself a reflection of their underlying health. But the second I want to mention is a feasibility concern. Now, I call this the Babe Ruth problem. I made up that term, don't cite me. But because a prospective cohort requires you to pre-specify the outcome, the exposure, the scientific question, and the population ahead of time. So it's like Babe Ruth calling his home run before he hits the ball. But in flu, unlike in baseball, it's not unheard of for the home run fence to move while the ball is in the air. So what we really want to do is to be able to look at these most severe events. Medical care, outpatient visits, hospitalizations, deaths, and we want to be able to do it with enough power and enough solidly measured variables to be able to do that well. And for this, you need what I'm going to refer to as the case-driven designs. So case-driven designs. First, I'm going to show you, here are some numbers of what you get in a case-driven design. And this is why I'm saying this. First, We've got, I've shown on the left, data from a 12-year cohort from University of Michigan that I now work with. And you see the number of cases that you get for different endpoints from all of these following these families. And then in the middle is the 1,700 cases of influenza that can be measured when looking at medically attended respiratory illness. And on the right, you see what comes from the hospital-based network, 1 season of IV. Much numbers you can do much more with, much larger numbers. Case-driven designs are beneficial in that they are adaptive. It's not unusual for the predominant influenza strain to switch mid-season. Here I'm showing an example where we have one strain very well matched to the vaccine on the left at the beginning of the season. But by the end of the season, there was another strain that was not well matched to the vaccine. And so you have this shift right in the middle. And then on the right, we see an example of geographic heterogeneity, where you have different areas of the country. We're seeing different flu strains that year that had different degrees of match with the vaccine. You require methods that are able to handle that shift, able to handle that adaptability that's needed. Now, the typical case-based design that we see is case control design, and I need to speed up. This design has had problems in the past. They've emerged as it's been used in the past because of important differences in access to healthcare in the infected cases compared to community controls. So this leads to selection bias, again, a byproduct of SARS-CoV-2. We've had some very recently published excellent studies looking at that selection bias. And what we can see that is if this selection bias is not managed, the vaccine will look more favorable than it is. In fact, there is a great systematic review on the right that shows an upward trend of studies that do not account for that selection bias compared to studies that use a test negative design, case definition-based test negative design, showing that test negative is the more conservative approach. So the test negative design, to be more specific, is resource efficient. It's adaptable to rapidly changing viruses. It can be done in a timely way, but it requires careful attention to internal validity. This means the use of a clinical case definition with attention to severity of disease. It means that you have to appropriately restrict your data to the clinical group of interest. If you are studying prevention of hospitalization, you should be measuring hospitalizations. If you're studying prevention of MARI, medically attended acute respiratory illness, you should be measuring those. And then you should be accounting for health status. And we've been referring to that as frailty in past papers, but there are efforts to do that. So along those lines, I wanted to end here. I believe that the scientific community, we have an obligation to deliver updated information when we have it to American taxpayers and make sure that information is relevant and is responsive to the changing situation on the ground. And we're being resourceful to the best of our ability. Can methods for tracking vaccinations be improved? Always. And we're working on that, and many others are working on that. So with that in mind, I wanted to end out on a shout out of sorts of recent efforts by CDC and partners of CDC to work on always improving these measurements and always improving these methods. These are some of the areas where those improvements are being made and continue to be made through a lot of incredible hard work, including better selection of controls and understanding the controls, understanding durability of immunity and the impact on estimates, accounting for health status, chronic disease, clinical decision making as part of both our data collection and the analysis of the data, and understanding exposure and outcome classification and making sure that that's as valid as possible. So there are far too many efforts to include here. I concluded the ones that I remembered in the kind of the short notice to do this. But I hope this makes it clear that the work goes on. It's continued by scientists committed to finding the best way to use these tools and then make them available within the constraints that we're working on to generate a body of evidence in the most efficient way that we can. Thank you.
Thank you, Dr. Martin. So our next presenter will be Dr. Martin Kulldorff. Dr. Kulldorff will offer a critical look at test-negative design, its key limitations, and make the case for stronger alternatives. Dr. Kulldorff.
Good afternoon, and thank you so much for inviting me here. It's a great pleasure. I have worked a lot with CDC scientists, and I have enormous respect for the enormously important and high-quality work that you do here. These are some papers that I wrote about vaccines with my CDC colleagues. I've also written papers on other topics with CDC colleagues, but they didn't fit on this slide. So it's a great pleasure to be here among you all. So this is similar to a previous slide that we saw, that there's a hierarchy of methods. Randomized trials is the best. Cohort studies, number 2, and self-control studies are also very good. Then case control studies, ecological analysis, and case reports. And doesn't mean that you can have a very good case reports or ecological analysis. They are very important, that you can do a lousy randomized trial, but this is sort of the hierarchy in the quality of evidence. Test negative design, that is a case control study. It's a type of case control study. And when we do any epidemiological study, the key thing is the controls must be comparable to cases. So in the randomized trials, that's the best because we randomize people, so they are very comparable. If you do a cohort study, we take them from the same cohort, and then we use covariate adjustments or propensity score matching or other things to make them, to balance them. And that's sort of the trick when doing epidemiology, to do that in a thoughtful and thorough manner. In a case control study, we need to select controls from the same population, same background population as the cases, and then we can do covariate adjustments also to balance things up. So which control group is best to use? So I'm going to leave infectious disease and vaccines, and let's do a case control study where we're looking at pancreatic cancer. What controls would you pick here? Should we pick, for example, lung cancer patients or maybe diabetics? Or should we do a sample from driver's license files? Or maybe we pick a sample from HMO members, or maybe we do patients hospitalized for respiratory disease. What do you think is the best choice here? Well, maybe lung cancer patients, that might be more similar. So is that a good choice then, since they're more similar to the they have cancer. These just different types of cancer, but would that be the best choice?
Depends what you're looking for. Depends on the question.
I see some people shaking their heads here. Well, let's suppose we want to know if smoking causes pancreatic cancer. Well, there are more smokers among the lung cancer patients, so we would then conclude that smoking is beneficial reduces the risk of pancreatic cancer. So lung cancer patients are not a good control group. If you do diabetics, maybe we'll find that if you're obese, you reduce your risk of pancreatic cancer. And if you do the last one here, patients hospitalized for respiratory disease, we might find out the more infections you have, you reduce the risk of pancreatic cancers. So and that's not a message that we want to say is true, because we don't want to recommend people to smoke and become obese and have a lot of infections in order to reduce pancreatic cancer, because it's not true. And in fact, smoking increases the risk of pancreatic cancer. So we should never select another disease as the control group. We should select the control groups from the same background population. If we have prostate cancer, we could select only men, for example. But we should select from the same background population. And then we might want to adjust for them from them being diabetics, for example, or for their if they have a lot of respiratory diseases or if they are frailty. So you might adjust for those things. But we should never select the controls based on another disease. So now we come to the infectious diseases. So which control group is best for COVID patients?
What's the question? What's the research question?
It could be different things, but it could be, for example, if the vaccines, the COVID vaccine reduces the risk of being hospitalized with COVID. It could be something else also, but the principles is the same, that we should not select another disease as the control group. So, for example, suppose we select other people who have an infection, come to the hospital with a respiratory infection or something, but it's not COVID. They tested negative for COVID. Well, it could be that they come from a more frail population. They're more sensitive to infections, and they know that. And because of that, they are recommended more strongly to get vaccinated. So it could be that those who come to the hospital for a different infectious disease, they are more frail, and therefore they have a different probability of being vaccinated. That's nothing to do with if the vaccine protects you against COVID or not. It just creates the bias. And the bias can go in either direction. You could also have a situation, for example, where maybe those who come in for another respiratory disease, maybe there was influenza. So they are less likely to come in if they have the influenza vaccine. And people who have the didn't have the influenza vaccine, they're also less likely to have the COVID vaccines. There's some correlation there. People often get the both or neither. So in one of these examples, the bias goes in one direction, increasing the estimate of the vaccine or the VE, and another one it goes down. So the bias with the test negative design can go in either direction. Or we could also have a little bit of each, and then it sort of cancels out. That could also happen. But the principle is the same, that we should never use as a control group in a case control study, we should never use as a control group somebody with a different disease. So if we use the test negative design, it's only valid if the negative controls are representative of the same background population. So if I took all of you here, for example, and we did a test, and some test positive and some test negative, that's fine because you come from the same population. Or if I took a random people from people in Georgia and I tested them and some were positive and some negative, that will give me a valid test negative design, because it's not, the control group is not a specific disease, it's just from the same general background population. And of course, we need to adjust for various things, and you can do that in a cohort study or in a case control study. We adjust for the disease and diseases and other covariates to reduce the bias. But when we select the negative controls with a different disease, we're actually increasing the bias. So we want to, in an observational study, we want to reduce bias. But in a test negative design with an alternative disease as controls, we're increasing the bias. And that's not a good idea. So here's one example where there was both a cohort design and a test negative design. Here was comparing people who were vaccinated against COVID versus those who had COVID and recovered. And then what is the risk then for a subsequent COVID hospitalization? And in a very carefully done cohort study, adjusting for a number of things, Gazet and colleagues found that the vaccinated were 8 times more likely to be hospitalized for COVID compared to those who had COVID and recovered. And that's sort of what you would expect, because vaccines are really sort of mimicking a true infection, except you don't have to get sick. So the advantage of a vaccine is to get the immunity, but without having to get sick and risking how to die. So that's the advantage of a vaccine. But you wouldn't really, it would be very surprising if they were more, if the vaccine had more efficacy than the natural infection-acquired immunity. When the same question was asked with a test negative design, the result was flipped. And those who were recovered, have had COVID, had 5 times higher risk of being hospitalized for COVID, which is very counterintuitive. But this is because a well-conducted cohort study is much more reliable than a test negative design that uses another disease as the control. So what is the alternative to do? Well, the alternative is to do a cohort study. And at CDC, cohort studies are used all the time for vaccines. The vaccines data link, for example, Medicaid and Medicare data has been used to look at vaccines, insurance claims data. And just one example, about 10 years ago, David Shea here at CDC led a study using Medicare data to look at influenza vaccine efficacy. So it's very possible, and we saw that before, it's very possible to use cohort studies. And it doesn't have to be prospective. It can be retrospective data. And it can be done in near real time also. So the Vaccines Data Link has an excellent program where they get weekly data feeds to look at vaccine safety, to see if there are adverse reactions. But you can use exactly the same data, exactly the same data feeds to look at vaccine efficacy. So it's very feasible to use cohort studies to look at vaccine efficacy in near real time. So why do we do the observational studies? Well, the ideal, of course, is to do randomized trials, but we can't always do that. So we should do them, and we should do many of them, and we should do them well. But no matter how much we do, we will never be able to solve all questions with randomized trials. So we have to do observational studies. That's very important. So just one example for the mRNA COVID vaccine trials, they were done randomized, placebo-controlled, and there was about a 95% efficacy against symptomatic COVID disease. But that doesn't tell us what's the efficacy for mortality, which is the more important outcome. In the trials, there was mostly young and middle-aged people, not older people. And that was the reason we couldn't answer the mortality, because they recruited young people rather than older people. If they wanted to answer the mortality question, which is more important, they should have recruited mostly old people, and they could have answered that question, but they didn't do that. So then we have to use observational data to answer those questions. Also, they terminated the trial very soon. 2 months, they published the papers, and they continued for a couple of months more. But what about vaccine effectiveness 6 months down the road or 12 months down the road? Well, we need observational data.
We were in a pandemic. That was why.
I would like to ask the audience not to interrupt the presentation and be respectful. Thank you.
Now, there was actually a brilliant scientist in Denmark, Christine Stabler-Ben, who figured out, well, we do not know what's the efficacy for mortality. So what she did, we didn't have sample size for each individual one, so she said, well, let's look at adenovirus vaccines, and which is AstraZeneca, Johnson & Johnson, and Sputnik, and she showed there was, using the pooling the clinical trials, randomized trials, she showed that there was strong efficacy of this vaccine. The relative risk was 0.37, so it reduced it by about 60%. And this is actually the best evidence we have for the efficacy of the COVID vaccine in terms of strong methodology. Now, still, this is only for young and middle-aged people because they were in the trials, and it's only short term. So we still have to do the observational studies to find these other questions. And I think I'm going to stop there. Well, so the other thing is, the public is very smart, so we can't fool them. There are a lot of smart people out there. They may not have studied epidemiology or medicine, but they are very smart. So if we want trust in public health, which is very, very important, we have to do very rigorous science, and we have to do honest communication, and we have to do what we're doing today, which is to have open scientific discourse and debate. That's the only way that we can have trust in public health. And that's our responsibility as public health scientists to ensure that trust is not something we should blame on the public. It's our responsibility to ensure that we have trust. So that's my presentation. So thank you very much.
So I am giving Dr. Dean the very, very hard task of listening to sometimes divergent reviews, particularly on test negative design and when you should use it, to tee up our discussion by synthesizing what you heard, particularly where there actually may have been some commonality, and then where there's some divergence, to open up for our discussion.
Great, thank you. Good afternoon, everybody, and thank you so much to the organizers for inviting me here. I really appreciate the opportunity to have this exchange in a way that is open to the public, and hi to those watching online. It's an honor to be here representing my fellow vaccine study methodologists. So I've been asked to kick off the moderated discussion. I'm going to step back and highlight what I think are some of the most important points. First, the test negative design, has played an important role in seasonal vaccine monitoring for 20 years, and we really have to give it its due. It is a creative solution to a difficult practical problem. We don't have infinite resources to enumerate and follow a large population in a big prospective cohort. So we focus our surveillance on cases, like Dr. Martin said, a case-driven design. And by using negative controls, we're mitigating, not necessarily eliminating, but mitigating a very real bias due to healthcare seeking behavior that is known to cause an overestimate in VE. I also wanted to add, because I didn't really hear it mentioned, why does this design work? It works because vaccines are a specific type of intervention in that they target a specific pathogen and not other pathogens. So flu vaccine prevents flu, but not RSV. Test negative design then has kind of a narrow use case for vaccines, also Wolbachia, very few examples. It doesn't work for exposures like smoking or alcohol use. It's a very narrow, relies on that underlying assumption. Is the design perfect? No, it's non-randomized, and confounding is always going to be an issue. It's restricted to a care-seeking population. Does that generalize to a non-care seeking population? I think so. I mean, vaccines are a biological effect, but you can have that debate. I've had concerns about, how comparable are test negative controls who are hospitalized when there's differences in the severity profile of pathogens, like when we had a lot of young people being hospitalized with COVID, and really if they were hospitalized, there weren't a lot of other reasons for negatives. So we adapted in a study we did in Brazil and used non-hospitalized test negative controls for that reason. So there are no shortage of discussions or tweaks that we can make to the methodology. And as Dr. Martin showed, the colleagues in academia and colleagues at CDC are exploring these until the cows come home and the journals are filled with all of the little sources of bias that we can identify. What the journals are also filled with are studies that provide some reassurance. Compared to RCTs, compared to a community control group, we've largely seen similar results. They've reassured us that we are getting the key information that we need to get, especially when we're not just relying on one study for that key information. We're pulling things together with many lines of evidence for decision making. But the important role of CDC is not only to say what are the limitations, but also what should we do on Monday morning? Because routine vaccine monitoring is too important to abandon, and we need to know what's happening. And if we're considering moving away in any way from something, we need to know what we're moving towards. Randomized trials, as fantastic as they are, and I work on randomized vaccine trials, just do not have a key role in year-to-year routine surveillance. You need equipoise, and you need a lot of money and time. It's just not going to do. It helps for some narrow questions, but not for the broad, just how are we doing this year? I think there's a much bigger potential discussion around retrospective cohort studies, as has been brought up by Dr. Koldorf and Dr. Martin, especially cohort studies that can be large because they leverage data from electronic healthcare records. This is particularly appealing for rare outcomes like hospitalization, also where we don't have to worry as much about care-seeking bias. But the reality right now is that outside of a few small healthcare networks, our data systems as a country are not fully ready. If you got your vaccine at your grocery store, is it in your medical record? Do they measure what strain of influenza you were sick with? So I hope we'll spend some time discussing sort of what would be needed to get those systems ready. So I hope we can have a more very practical discussion about what our country should be doing, investing in to have this full awareness for our vaccine monitoring. And I again thank the organizers for this opportunity and pass the mic back to begin the discussion.
Thank you, Dr. Dean. So we chose the title for this session for a reason. We said practical approaches and considerations. So as we move through our discussion and our moderated Q&A panel, I want us to think about concretely what we would do. As scientists, we love to think about the optimal, but I think the panel actually presented some real life challenges to the optimal and their considerations on how we have to adjust design to get the best estimate even when we can't do the optimal. So I'm actually going to maybe start with you, Dr. Kulldorff, to talk to answer the first question, and then I'll go to Dr. Martin also for this question. So one of the things that was suggested is that test negative design was really designed to deal with some trying to eliminate some of the healthcare seeking bias, but there may be other sources of bias as well. How do issues like partial immunity, waning immunity, season vaccination, are there other things that we should be considering when we look at the validity of these vaccine effectiveness estimates? That's the first question. And what adjustments are commonly made, and where will we still see residual confounding? So that's the first question.
Thank you. So I don't think that the test negative design, when you use a different disease, takes care of healthcare seeking behavior, because you have somebody who comes in for COVID, and then you have somebody who comes in for a different disease. Well, they have different symptoms. So the level of when you seek healthcare is not going to be the same for two diseases. So I don't think that the test negative design solves that problem with healthcare seeking behavior. I think you can do it in a retrospective cohort study, because you can go back and see the history of the patients for a few years and try to adjust it that way. But I don't believe it's properly adjusted for using a test negative design. And what was the second?
And the question is, are there other factors we should be looking at that can be causing underlying bias?
Yeah, you also mentioned about the residual effects.
Mm-hmm.
And one danger of the test negative design, which doesn't always happen, I think, but I think it can happen, is that if you select a control group of a different disease, and then you try to adjust for something that's very similar to it. Let's say your control group is diabetics and you adjust for obesity or something like that. Then there could be residual issues, because they're very correlated. They could get into residual problems which can give very strange results. So I think it's a risk if you both then do the control group of a particular disease and then try to adjust for something that's very similar to that. because then you're sort of doing it twice, and then the correlation and the residual can mess things up. So thank you.
And I wanted to turn to Dr. Martin.
Yeah, I very much want to answer the question about partial immunity and waning immunity, but if I could first clarify a few things. One of the things I really like about the systematic review that I presented was talking about a clinical syndromic case definition. I think that is critical. And I think it's critical as we talk, as Dr. Dean mentioned, about if we were to move towards using big health systems or medical records, that's still where we're running into challenges. And so I'm going to push back slightly against your, they have different symptoms or they have different levels of severity. If a control comes in versus a case comes in, that's the purpose of the clinical case definition, is to do everything you can to make sure that the clinical syndrome that the case comes in, it matches between the case and the control. And that's where I really like that review that showed that it actually can bias your estimates if you're not doing that well, but there are ways to do that well. Now, and then to your point about healthcare seeking behavior, history of healthcare seeking, absolutely. I think we've done some work, the most complicated test negative design study I ever worked on was Haven, which is a hospital network. And we looked at history of healthcare seeking behavior and incorporated that into our analysis and estimates and found that it was able to help us improve our estimates. It didn't make a huge difference, but it was able to tighten things up a little bit. I think that is not as much of a concern as something, for instance, like survivorship bias, which is, something in the Gazette paper that you presented has been brought up as an issue with that data set. So other than the brass tacks, I don't want to take too long, but I think that partial immunity, waning immunity, I think this is a great example about making sure you're choosing the right tool for the right question. I think with the rapid assessment of VE, we can take into account what we know about partial immunity and waning immunity. Waning immunity actually is a broad term that covers two concepts. There's one where I gave examples of the estimate changes mid-season because the virus changed, but then that's breadth of protection. But the other thing you see with waning immunity is duration of protection. Does the vaccine effect wear off over time? And so if both of those are two different biologic phenomena that are happening in interplay with each other. So it really requires cohort studies with specimens, studies where we're measuring immunity. And actually, there are some efforts to incorporate that into test negative design, although the assumptions are big to be able to do that. And so that's where, because it's a biologic effect, we can turn to cohort studies to be able to really define the mechanism of what's going on there, and then understand how to bring those in to our VE estimates in the most appropriate way.
Right.
That's what would be my.
Thank you both for those responses. I'm going to shift a little bit and kind of get into the public health messaging conversation. I think we heard a lot of what for some people is complicated science who might be listening. But in the reality, we still have to message even when people don't understand what bias is and all those things. And so this question, this question I'm going to direct to Dr. Reed and then Dr. Dean. So we have decisions at stake. When a vaccine effectiveness estimate changes during the season, how do you communicate that to decision makers and to the public? And does the study design, whether you did test negative design or you did a cohort study, does that change how you communicate that? Is there uncertainty or levels of uncertainty that you might communicate? I'd love to hear from you.
Yeah, thanks. I think this is one of the areas where the development and expanded use of the test negative design here and many places around the world really allowed us to investigate some of those questions, the things that we would want to be able to communicate people about what's happening in that season in a more timely way. And as has been discussed, that isn't going to answer all of the questions that we have, but for being able to see what's happening, being transparent about what we're seeing, especially in years, as I mentioned, where we see viruses circulating that have drifted from the strain that was selected for the vaccine. Can we get early insights on what is happening and then communicate not the technical aspects of the studies themselves, but how this compares to what we've seen in other years, or how we think this impacts what we would recommend to the public, to clinicians, about whether or not they should bother getting vaccinated, right? There's still, for influenza, there's more than just one virus in the vaccine, and so there's more than one virus circulating, and so there's still maybe protection from other viruses. That's a message we try and get out commonly when we see one of the three major viruses has drifted. Reminding clinicians that antiviral treatment is available and is important for those people that still get infected during the season. And so I think those communication messages are not so much about the nuances of the study and the study design, but of what we're seeing and how it compares to what we would expect to be seeing, how it compares to what we're seeing in other countries, in other studies, and therefore, what are the messages that we want people to take away from that information. And, you know, we historically have been putting out the interim estimates from our VE network and our various VE networks now around February for public transparency in the middle of the season, but also because that's when our vaccine consultation meetings happen globally around strain selection. And so those really up-to-date information about what we're seeing for the vaccine this year compared to what we've seen in other years, how it compares across components of the vaccine. And really, as Dr. Martin mentioned, having specimens and enough cases and enough diversity to be able to stratify on some of those important issues that could help make decisions about what virus to include in the vaccine for the next season with the most up-to-date information.
Thank you. Dr. Dean, would you like to weigh in?
Yeah, I can just reinforce that a bit and try and, yes, and build on it a little bit. So, I mean, I think we're all, as scientists, a little Bayesian, right? Like we have our ideas about, you know, what we expect to see. And so if we see something different than what we expect, that sort of signals that we need to explore what are the underlying reasons and sort of triangulate why that change might have occurred. Is it a real kind of signal, or is it just sort of an artifact? Was there strain evolution, strain switching, an issue with the formulation? I would say that I have a mental model of kind of what study designs work best with what types of questions and outcomes. But in general, I'm more looking at the size of the study and the rigor of the study. So, I mean, large national networks, I'm going to give more weight to than single site studies. But in the end, we're even if one study says something, we're also looking for other confirmation at other external lines of evidence. So is it replicated in a different country with a different population, different methods? So, and then is there a plausible mechanism? So those are the things that go into the thinking.
Right. And I actually think this next question I may ask for several of the panelists, and maybe I'll start with you, Dr. Koldorf, but I'd love to hear Dr. Martin and Dr. Dean all respond to this question. What do you think the single biggest limitation is for our current monitoring systems for respiratory virus? And if you could make one change to improve our real world vaccine effectiveness evidence, what would you do in the near term?
Thank you. I would use the enormously valuable data sets that we have, cohort that we have retrospectively. For example, the Kaisers that we use for the vaccine study data link. It's fantastic data. There are other use the Medicare data, the Medicaid, also commercial health insurance. And Dr. Dean made a very important point, saying that some vaccines not in the electronic health records. They are so they're not available there. So what we do when we do the vaccine safety work is we connect those data sets with vaccine registries from the states, and then we can get additional vaccines there. So we should do the same thing for the vaccine effectiveness studies, bringing in those registry data. And I think it makes sense to use to utilize the systems that already are in place in at CDC and other places for vaccine safety to also use them more for vaccine efficacy. It has already been done to some extent, but to sort of utilize, because it's the same data. It's the same data sets and many of the same methods also. So I think to move towards doing using the retrospective data to do retrospective cohort studies, incorporating the vaccine registries. I think that's the way forward to look at vaccine effectiveness. That's how we get reliable estimates. And it's not about showing that vaccines work or not. It's about getting the right estimates. And my guess is if we took the test negative designs and sort of repeated it in a cohort design instead, in some cases we'll find that the vaccine effectiveness will be higher and some lower and sometimes the same. So it's not about believing that vaccines work or not. We're here to figure out what is the best estimates. And to do that, we need to go to the cohort designs.
Dr. Martin, then Dr. Dean, please.
So I agree with that point broadly in theory. Actually, in a clarification, the current flu VE networks do already connect to the state vaccine registries, but because we don't have a national vaccine registry, it means that these are piecemeal efforts. And so they are only as efficient as we can gather from all these different states. So, I agree with you, but we need a national vaccine registry in order to do that, to be honest. But the other thing, like the thing that I would really want to be able to use healthcare records the way they do in other countries without our is because of our fragmentation. Clinical testing is happening for wildly different reasons and at wildly different rates around the country. That needs to be squared up. As we do that, something that active surveillance networks and the kind of medical record-based networks, where the big gap is that medically based clinical testing doesn't usually identify the strain. And so then we've just taken a huge step back in understanding what's circulating and what's around and being able to respond quickly to those mid-season shifts that we pick up in surveillance networks. We don't pick them up in the medical system because they don't drill down to the actual virus. They just say, we know they're infected. They might say, we know they're infected with flu A or flu B, but they'll never say an H3 strain that is drifted and is a different subclade than last week. And so that's what I would love to see advances in terms of infrastructure.
Thank you. And Dr. Dean.
Yeah, so a few points. I feel like a nice place to head, right, is towards being able to leverage kind of the best parts of both. And so I think, being able to leverage healthcare records, but then also if, it's been brought up, can we get a sense of what people's healthcare seeking behavior is? Because I do think that is a persistent issue with bias. And so, but just the electronic healthcare records as they are, right? Because of inconsistent testing, because there's just some parts that remain high touch, and so I guess it's like figuring out what the parts are that where you need additional data collection, you need additional sequencing, you need those things. Like, so it can't all be passive, I think so. Building some of those systems to support, what is the targeted additional data collection that needs to occur to support the electronic healthcare records?
Thank you. And I'm shocked at how fast the time is going. I want to open it up to Q&A in the audience. And so we do have some time for audience questions. So if you have a question, please go to the mics on either side of the room, and we'll take a few questions for the audience.
Hi, my name is David Shea, and I'd like to take you back about 20 years or so, at least, when Nancy Cox in the influenza branch, it was a branch then, said that we need to get better estimates of the yearly effect of vaccines. And one of the issues at the time was existing studies were being done using large database studies with nonspecific outcomes like pneumonia. We were getting estimates that half to 80% of pneumonia was being prevented by influenza vaccines. And that didn't make baseline sense. And the issue that was later shown by Lisa Jackson and colleagues, including Mike Jackson as well, what was then Group Health in Seattle, was that the vaccinated group was actually healthier than the non-vaccinated group, which makes sort of sense when we're thinking about older people who are perhaps at great risk of dying in a particular season, have cancer or are very frail and cannot get out to the doctor to get vaccinated. So we were seeing spuriously high estimates of vaccine effectiveness. And what we came up with is we would depend with new PCR technology, we had a very specific test for flu. So RT-PCR positive flu was a very specific test. And that's what you really need to define cases carefully. And lots of studies, both practical and theoretical, have shown that that's the case. We initially started this work with Marshfield Clinic in Marshfield, Wisconsin, and we looked at a variety of approaches to estimate vaccine effectiveness using PCR-related outcomes. One of the things we noted was that testing, of course, varies by clinician, by clinic, by type of facility, by physician ordering the test, and you cannot depend on clinical testing alone to find an accurate assessment of cases. The other thing we tried to do initially, as Martin suggested, was look at people who were not vaccinated in the cohort of Marshfield Clinic, which was a closed cohort at the time. And we found that we had great difficulty in controlling for a propensity to seek health care. Many unvaccinated people had little to no contact with the medical care system at the Marshfield Clinic. So we were not able to sort of balance the population, if you will. Martin, I totally agree. We want to have the same source population for our cases and our non-cases. But we were not able to do that effectively. And so that's when we started talking to Danuta Skronsky and Gaston de Series in Canada and decided to try the test negative approach in the United States. And has been amply shown many times in seasons where we have direct comparability between RCTs and test negative designs, in specific age groups, we tend to find estimates that are fairly similar, which increases my confidence that they are finding a true effect. My question for you really is this. You pointed out a study where we used Medicare data to, in a retrospective design, to look at VE. And what we actually did was compared two vaccines. So high-dose influenza vaccine versus normal dose influenza vaccine in a particular population, and our outcome was mortality. So we were looking at a very rare outcome that is really, you need the entire cohort of the United States, older folks, to look at that outcome. And we had the incredible good luck for that season, not good luck, but planned that way, that there was an assessment done, an RCT done in the few years before, and we were pleased to find that our estimate of effect against mortality in consistent seasons was similar to the effect for just prevention of flu in general in that population in an RCT. So I think it's been articulated that the question drives our choice of study design. In some cases, it's appropriate to use existing medical record data. In other cases, where the definition of medically attended flu, for example, cannot be ascertained by looking at retrospective records, because the testing, in the way that the flu VE and other VE networks do these tests, is people who come in with a certain symptom set get tested prospectively, not dependent upon clinician data, but prospectively. So my question is, how do we, in your assessment, how do we properly ascertain and get rapid assessment of VE in what you have sort of described as what you see our future? And then
Is that a question that's directed to Dr. Kordorf?
Yes, that's directed to Martin.
Dr. Kordorf, would you like to address that question?
Yeah, thank you. So there's two things I want to comment on. One is how do you actually know if somebody is sick or not? If they have COVID or if they have influenza? and that has to do with the sensitivity of the testing, and of course also with the specificity.
Specificity is more
It doesn't
important.
matter which of these methods we use. We need good sensitivity and specificity, and without that, it's very hard to
Right,
do
we need a very
good
specific.
job.
We can miss some cases as long as we are not calling an illness non-illness.
So
We don't have to have all cases.
So having good sensitivity and specificity, I think, is important no matter what method one is using. When it comes to the healthcare-seeking behavior, if we select those who have the other disease, I think those are two different diseases. The symptoms are different. And
Well, they may be, Martin, but in the case of general outpatient upper respiratory tract disease, as was explained, we can look for case definitions that are comparable, and so that the people who show up for testing aren't anybody who kind of feels ill, but are people who have acute respiratory illness and perhaps in younger children have a fever, for example. Again, I think you're making broad statements without specific data to support your conclusions.
So when we want to adjust for healthcare-seeking behavior, we shouldn't use the actual healthcare where they come in for the and when they are tested. We should use it based on historical things, and we can know what, for example, if somebody had not been vaccinated and don't come at all, we know that because there's no records for them having come in. But we can look back historically for a few years and see how often do they come in for various things.
Right, and we've controlled for that. We've tried to control for that in the past, and as has been described, sometimes it adjusts partially for that. In other cases where we're looking at young children, for example, who 2 years of age or less, for example, and don't have several years of past history, that approach would not work.
So when we want to adjust for healthcare-seeking behavior, we shouldn't do the current visit. We should do it based on the historical things, because and we can do that if we have electronic health data. So I think that's the best way to do it.
I've taken up a lot of time.
I've done.
All I wanted to say was,
Yeah.
Martin, I'll go back again where I started with Nancy Cox. Nancy thought of these issues 25 years ago. And it's part of the reason that we started at CDC to do assessments of influenza vaccine effectiveness in a more discrete, more controlled, more thoughtful manner. Thank you.
And thank you. And we're running low on time. But I would like to get at least one more question in, because I know you were waiting. So let's get one more question in, and then we will have to close. But I love this discourse, and we will be having a reception in the lobby. You can continue to have this discussion.
Yeah.
So next question.
Okay. Thank you for this opportunity. My name is Long Xiang. I'm the chief of the biostatistical office in the division of the bacterial disease. So I do a lot of vaccine effectiveness study too. My question is like this way, which is, I mean, this is a great panel. I think actually you guys actually emphasize the great thing about the cohort study. It's important. And also I can say that your discussion about that, because we cannot do cohort, even we go to those medical database or whatever, we don't really be able to ascertain vaccine status and disease status. There's many things. But my point is that given those limitations, in the CDC we are actually doing a great mental exercise. When we move from the clinical trial to the cohort, when we move the cohort to case control study, we always feel that, imagine that what happens if we have ideal condition to do cohort or do actually a random control trial. And then what kind of limitation when we reduce to this case control study or test negative design, and what kind of limitation will happen, and so what kind of the hypothesis we have to make, what kind of adjustment we have to make, as well as the what kind of sensitivity analysis we should conduct. So it's not just a blind statement that we go to that something simple and doing something actually immediately give you results. It's a very complicated process, which is we have to, consider compromise what the data limitation is, but those whole mental access, like a limitation of randomization and limitation of the, not being able to follow the cohort, we consider that. One example, for example, we recently did is that, for test negative design, very few people really consider the effects of the time. But however, if your vaccination status is changing over your study period, time needs to be considered. It's difficult to think about that way, but if you go back to a cohort, you will feel that you have to make an adjustment. You have to consider the time. And then when we go back to the test negative design and how this time factor should be controlled, should be, deal with. So that's what I'm saying that, yeah, it's not perfect. We all know those kind of problems. But we are doing very actually strict those kind of thinking process, like those health-seeking behavior. We need to get to the model to really think that what the health-seeking behavior is going to be. And then we use those model to do sensitivity analysis and also to actually say that what kind of adjustment we need to do. So this is basically what I'm saying that you guys agree to saying that, point to those obviously mistake of the, test negative design, but we actually doing here is much more sophisticated. We really consider that all those limitations and doing whatever we want to do. Thank you.
So with that, that was more of a comment, not a question. So I'm going to wrap it up. Thank you all. Because I'm going to ask Dr. Bhattacharya to come back up to the stage and offer us some closing reflection on today's discussion.
I just want to close by thanking the panelists for their robust and spirited discussion and for talking about sharing their expertise and insights today. And I think the thing I want to come away with is that we owe each other this kind of discussion, an honest exchange of ideas with each other. We owe the public the very best regarding the truth so that we can help them make the very best decisions about their health care. And I think it's only by having these kinds of discussions openly, it's not always the most comfortable thing, but that's the only way we can get to the right answers for the public, and then also get the public to understand that we are trustworthy, that we do care for their health and we care for the truth. And I'm so grateful for the panelists today for their contributions to that, and grateful to you all for your contributions to that every day. Thank you so much.
So I'm going to close it out. I want to thank you, Dr. Bhattacharya, and everyone who joined us today, both here and in the room. A recording of the session will be made available. I do want to ask you to take a moment to fill out the session evaluation. It will inform the future grand rounds. Your feedback is super important to us, so scan the QR code. And I also want to remind people that CDC Public Health Grand Rounds, our relaunch will be an ongoing quarterly series. Hopefully we will get back to monthly like we used to do in the past. So please be on the lookout for the next call for topic proposals and the announcement for the actual date of the next Grand Rounds. We hope you'll join us for future installments. Also, we will have a reception immediately following today's Grand Rounds in the lobby. And thank you for joining us today.